Absolutely. So it flows on from the previous points. Look, we understand that healthcare insurers, whether they're public or private, they're looking to get a fair deal and to treat their patients efficiently from a cost perspective. And our industry is the only healthcare industry that contributes to that in any material way. And you can look at any statistics in any country to see the difference our industry makes, and you will see a dramatic contribution to efficiency, to cost efficiency. I think the challenge we face is that a lot of payers and health ministries, what they are in a way obsessed with is the lowest unit price of any molecule. And they want to get the lowest unit price in Europe or in the world or what have you. And to a certain extent, you see it even in the private markets, for example, in the US, similar phenomena occurring. And I think this is simply incompatible with sustainability of the industry. We cannot invest in this kind of framework. If governments and payers would look at this as a system, what are the kind of cost efficiencies that our industry as a whole can bring to the system to enable sustainability for health insurers, public or private? There you totally change the dynamic, and our industry can still bring massive contributions. We talk about biosimilars, we talk about complex products, we talk about value-added medicines that are an inexpensive form of innovation that can help with a lot of the costs and the challenges for patients associated with chronic diseases or even infectious diseases to a certain extent. Repurposing, Sudarshan has mentioned, is a cost-effective investment for innovation. We can change the dynamics. Evergreening, if we put an end to the worst evergreening process, we can save almost the equivalent, of the generic market in savings. So, there's a lot that can be done if we look at this as a system, and our industry will be the major contributor. But if we look at it at the unit price of each molecule, how can I get to the bottom as soon as possible? That leads to withdrawals. A study commissioned by the European Commission on the root causes of shortages has looked at this, and they've noticed that almost all withdrawals of medicines, often generic medicines, occur when they are at a marginal sales level of 100,000 euros a year. At that point, the product is just withdrawn, and permanently, meaning there's no more access to that molecule in Europe or in that country any longer. So this obsession with pushing the prices, unit prices lower and lower is a recipe for disaster. On the other hand, a systemic approach focused on patients, this industry can and will deliver.
If I can link this back to the supply chain discussion you raised in the first question, because in the United States, we, for the first time ever last October, published our list of essential medicines. And when you look at that list of essential medicines, those that are most critical for in a health emergency and for the US healthcare system, those are the products that tend to be high volume, low price products. And so the exact medicines that the US would like to see manufactured in the United States, and that's what they're basing that kind of the broader goal of US produced products, those are the same products where prices have eroded to such a degree that you're seeing shortages in the marketplace for the reasons that Adrian had identified. And so it's not an issue of does the company want to produce those products, it's with the price where they're eroded down to, is it actually feasible for them to manufacture for certain products in certain markets? Now, I misspoke a little. Those products, our companies have been able to keep those products in the marketplace, but when you correlate that to the FDA shortage list, you'll see the prices on those essential medicines where they've eroded are the ones that appear on that list.